Aloha and good morning from the Hawaiian Eye Conference in Maui. We're pleased to be here today with Dr. Kendall Donoldson from Miami, Florida. Thanks a lot for being with us, Kendall.
Thanks so much for inviting me again, Jonathan.
Kendall, I want to speak with you about today about a topic which you've studied, which is the effects of diabetes on cataract surgery. And we should point out that although most of us tend to think about the posterior segment complications associated with diabetes and cataract surgery, such as retinopathy, sometimes overlooked are the anterior segment issues. And I know that you've looked closely into that. Can you explain your study, please?
Absolutely, Jonathan. And I think you're exactly right. When we think about diabetics and cataract surgery, we think, really 20% of our cataract surgery patients are diabetics, and they tend to be a bit younger, and so it's a working population. So really, it's a group that we really need to pay special attention to. And we tend to think about the posterior segment complications, such as worsening of macular edema or diabetic retinopathy. However, oftentimes we don't really think about what this means to the anterior segment. And these patients tend to have smaller pupils in general, which can lead to a longer case. And when the pupil is smaller, that can be associated with many other complications, including damage to surrounding structures, such as the posterior capsule, the iris, and the corneal endothelium. It's been pretty well established through the years that diabetic patients have a lower endothelial cell count to start with in comparison to non-diabetic patients. However, what we wanted to look at is what happens with cataract surgery, what happens to that endothelial cell count, and how many cells are we losing during cataract surgery, how traumatic is the surgery to diabetics versus non-diabetics. The unique thing about our study was that we had matched 70 patients that were diabetics to 70 that were not, and we matched them very tightly for age, size of cataract, axial length, anterior chamber depth. And, there really are a lot of different variables that can come into play when you're looking at endothelial cell loss. So we wanted to make sure we controlled as many as possible so we could really look at endothelial cell death. And we found a 15% cell loss in the diabetics compared to 11% cell loss in the non-diabetics. And this was actually a significant difference in these patients.
Well, it's important that you bring that up, Kendall, because one of the things you also mentioned is that patients with diabetes may start off with a lower endothelial cell count to begin with. And if there's a higher percentage of loss, then the absolute count at the end of the procedure would be substantially lower than for diabetics than non-diabetics. Is that right?
Absolutely. So in our study, we did match them for endothelial cell count, but in reality, they do start out with a lower cell count. So that's even more significant in those patients, exactly as you said.
So then, Kendall, what are some things that we can do either preoperatively or intraoperatively to try to mitigate some of these findings that we know about? How can we try to preserve the endothelium better, and how can we try to ensure that we're not introducing damage to other intraocular structures?
Absolutely. So the clinical significance of this is what really matters, as you mentioned. So I think it starts with advising the patients preoperatively. So it's always better if you can anticipate an issue to possibly occur that we mention this to patients before surgery, so then they don't really consider it a postoperative complication. They know that it's a possibility and they're already prepared for it preoperatively. Also treating the patients both preoperatively and postoperatively with adequate nonsteroidals and various anti-inflammatories, including steroids. I think over the last several years we've talked about how to reduce drops and how to reduce anti-inflammatory treatment for these patients. But we really need to remember this is a high-risk group, and trying to reduce the anti-inflammatories can be dangerous in these patients. So we really have to pay extra attention to treat them properly for potential inflammation. And then finally, using all the tools. We're really spoiled that we have great surgical tools, great instruments, using things like Malyugan rings, intraoperative infusion of phenylephrine and ketorolac, and maybe even getting a preoperative OCT in these patients. So if a problem does occur, we have a preoperative measurement to compare to.
That's a really great point, Kendall. And one final thought before we close. I'm kind of curious about whether or not the extent of diabetic disease makes a difference. And what I mean by that is that, of course, we know that diabetes is not a binary problem. It's not a yes or no, but rather there's a continuum and a range. Some people with a hemoglobin A1C in the mid to high sixes might be at different risk, per se, than someone with a hemoglobin A1C in the double digits. So do you think that the extent or the severity of diabetes plays a role here?
Yeah, and actually that's a very interesting question, Jonathan, because that's exactly what I thought. So we broke down our patients into patients who were well controlled with hemoglobin A1Cs of less than 7, and we compared those to patients with a hemoglobin A1C of greater than 7, so they were out of control diabetics, and we didn't find that there was a significant difference in those two groups. I think it needs to be looked at a little bit more thoroughly, and it would make sense that on some level we'd find a difference, but we weren't able to detect it in our study.
Well, that's a really great point. Kendall, this has been such a fascinating look for us about how diabetes affects the anterior segment and how we need to think about these specific issues when doing cataract surgery on patients with this medical problem. Thanks so much for sharing your expertise.
Thank you, Jonathan, for the invitation.